Welcome to Chest Pulse. I'm Dr. Megan Conroy. I'm an assistant professor of pulmonary and critical care medicine at The Ohio State University in Columbus, Ohio. And today I'm here with Ryan Maves to discuss using the first 5 minute strategies for addressing vaccine hesitancy, building trust among patients, and emphasizing the importance of vaccinations for those with chronic pulmonary conditions. Thanks for joining me, Dr. Maves.
Well, thank you for having me, Dr. Conroy. So I'm Ryan Maves. I'm a professor of medicine and anesthesiology at the Wake Forest University School of Medicine in Winston-Salem, North Carolina, in the sections of infectious diseases and critical care medicine. I'm a practicing intensivist, but also the medical director of Transplant ID here at Wake. So thanks a million for having me, and looking forward to talking about this important topic.
Absolutely. So let's take in your expertise. Let's dive right in. And I'm curious, in your experience, what vaccine safety or advocacy concerns do you most often hear patients express?
Yeah, in my particular practice, the place where this comes up most often is in people with various forms of advanced organ failure who are at least being considered for transplantation. Now, this is kind of a final common endpoint of a lot of the patients we see, but I also have seen this in earlier phases of my career where I was practicing in more of either a general ID population or in folks with well-controlled HIV for whom I was effectively their primary care physician. I think the big concerns kind of fall into a few major categories. So one of them is the sense that the incremental benefit to them or to themselves is relatively low. So a common example is influenza vaccination, where when you're dealing with a largely young and healthy population, the perception is that influenza is just a cold. The vaccines aren't that effective. I don't like getting shots, and I'm not likely to personally benefit from this that much. Therefore, why should I bother getting a flu shot? So that's, I think, probably the most common one when we look across broad populations is one of thinking it's not going to make that big of a deal for me. Why should I put myself through it? We then get into kind of broader concerns about vaccine safety in general. And those are things often related to side effects, often related to perceptions of inadequate testing or of side effects that are inadequately explained. Very rare events like, for example, Guillain-Barré being magnified into very common events, or other immunologic effects of vaccination. This can be a little more challenging because we're dealing with problems that are real. They do exist. People do get immunologic effects post vaccination. They are rare, but they happen. Or perhaps related to side effects that are genuinely common. A common example would be the recombinant zoster vaccine, which is marketed as Shingrix. People pretty reliably feel lousy the day after they get their Shingrix. I was in the military for a long time, so I've been vaccinated I've had the entire rabies series more than once. I've had anthrax vaccination. I've been vaccinated against everything at one point or another. And I've been lucky. I've had relatively trivial side effects, if any, from most of the routine vaccinations I've received. The day after I got my Shingrix, I felt tired. I felt wiped out. And I knew that was coming. I was prepared for it. Obviously, I've been giving this vaccine for years. But, people knowing that they're going to feel kind of blah the day after a vaccine is a disincentive to them getting it. And that can be magnified if it's in the setting of other kinds of vaccine concerns. Then kind of lastly, what we deal with are, I'm going to say the less evidence-based concerns about vaccines. And sometimes it drifts into conspiratorial thinking. The belief that, for example, that the measles, mumps, and rubella vaccine in children was associated with autism. Very short answer, it is not. In fact, if anything, rates of autism are lower in fully vaccinated children. This is based on data coming out of multiple countries. The other concerns are that, vaccines were rushed or inadequately studied prior to being released. And obviously, this is a thing we've seen with the COVID vaccines. And it is true that the phase 3 trials for the licensed COVID-19 vaccines were were done very quickly. Now, they're done very quickly because we're in the midst of a pandemic, and it was very easy to get large numbers of patients and establish efficacy quickly. Um, However, that perception, that belief is a hard one to overcome. And that is, I think, one of the big challenges that we need to discuss today.
Yeah, absolutely. And I think I've seen examples of all of those things that you discuss having seen there, and even actually had several of those conversations just yesterday, in fact.
Yeah, me too. So in your perception, can you share some of your insights since we're talking about your own practice, about the psychological or cultural and maybe some social factors that you've encountered in your practice that may contribute to vaccine hesitancy among our patients?
Yeah, absolutely. And I think, in thinking about this, and when we think about vaccine hesitancy in general, I have a tendency of thinking, well, what do I see, and is that normal? Is that representative of the whole? And it's interesting when you look at the data on vaccine hesitancy and looking at questionnaires and trials that are looking at COVID or influenza, often vaccine specific hesitancy. We see trends, varied papers that will call trends geographically differently, that will call trends ethnically differently by different cultural groups. And I think something that this really drives home for me is that, in the United States, these United States of America, we are actually quite culturally diverse just state to state. We are a very large geographic area, and the area that I practice in the Midwest has a different kind of culture just generally here for those who are born and raised in the Midwest than we see in North Carolina where you practice. And that's different from other areas in the South and in the West. And I think it really can't be understated that we can't necessarily generalize entirely across the US, that there is a lot of variation from region to region and state to state. And within those states, variation among different ethnic and cultural groups and gendered groups within those states. If you look at some studies, one study in COVID vaccines suggests that, being Hispanic in Florida is associated with higher hesitancy to a COVID vaccine compared to being Black in Louisiana is being more associated with hesitant to a COVID vaccine. But those ethnic trends don't hold up in the Midwest. And so I think recognizing that any individual is going to be honestly very specific in their history, in their culture, in their identities, and in their reasons for being hesitant to a vaccine, in ways that we really can't generalize across groups or even across the country. And for me, that really kind of drives home the importance of understanding that individual, their individual story, not just their demographic identities, but really using the power of our relationships with our patients to better understand where they're coming from. And I think also when we consider what are the social, what are the cultural undertones to this, certainly you touched on several of some of our the zeitgeist in current years around vaccine hesitancy. Um, but also considering, in medicine, we have a long, well-founded history of mistreatment of persons of color as institutions, as medicine as a whole, and that really can create generational mistrust, which is well-founded across medicine. And so acknowledging that, understanding that, and I even find it very powerful, honestly, naming that at times with my patients. As a pulmonologist, we have examples of systemic racism in the way that we interpret pulmonary function testing that historically had a detriment that we reduced the expected lung function for persons of color or of Asian background. And I find it actually very powerful with my patients just naming this history, recognizing it, and then in being open about that and discussing that, finding that it's easier in building that relationship for them to share with me some of their hesitancies or mistrust that might stem from some of their different identities, cultural, ethnic, and such, that might inform some of the reasons for their hesitancy. Almost because it just creates this open dialogue between us where we're able to discuss these things. And so, the things that I'm seeing and hearing are honestly very different. The catchment area that I serve, I have some individuals that are of very rural settings, and I hear sort of low risk factors that they just aren't around as many people. They don't think it impacts them quite as much. I have some individuals who come with more conspiratorial concerns and having heard a fair bit of misinformation in their circles. And so we work to help understand what's most concerning to them and try to make sure that the information that they have is accurate to make their own decisions. And then others who really sort of, have just a lot of concerns on side effects in the short term, and really want to make sure that they're kind of making the health decisions that are best for them.
Yeah, no, absolutely. It's funny. I grew up in a very small town of, it was 350 people when I was a kid. It's grown to 370 now, so it's very much a town on the grow. And although I did not grow up in North Carolina where I practice, I recognize a lot of the concerns of a lot of my more rural patients out here. And when we're talking, I actually find that kind of useful to, I don't want to say leverage, but that may be the best term actually, to leverage that relationship and say, hey, listen, I grew up in a place not unlike where you live. And I respect and I understand those concerns. And then we start to talk it through. And I recognize that I may not crack the code on that given patient on that visit. But if I hear them out, if I give them a chance to voice their concerns, and we make plans to see each other back, I know that I think in time I have a reasonable chance of persuading them. And I think that alludes to a lot what you're talking about how trust is a fragile thing, how it takes time to build. It's very difficult to establish and it's very easy to lose it. And it requires a lot of patience to make it happen. For those just tuning in, you're listening to Chest Pulse. I'm Dr. Ryan Maves with Dr. Megan Conroy, and today we're talking about using the first 5-minute strategies to address vaccine hesitancy. So, Dr. Conroy, now that we've talked about some common reasons for vaccine hesitancy, can you talk about how you use the first 5 minutes communication strategies and what steps you take when discussing vaccinations?
Yeah, absolutely. For those who may not be familiar, the first 5 minutes is a communication technique and educational series that is available from CHEST to help you in connecting with a more diverse set of patients. And using the first 5 minute strategy really are our communication techniques as well as some introspective techniques to help make sure that we're creating individualized spaces to allow our patients to really get their full concerns across. Some of the strategies that we're taught in first 5 minutes are things like, first pausing to assess our own implicit biases that might impact conversations and approaches that we're having with patients. As we apply this to vaccine hesitancy, I think taking a moment to consider how your own emotional responses have maybe impacted or changed with regards to vaccine hesitancy. I know that personally, in the last 4 years, I have at times had some degree of burnout or frustration with regards to having conversations what sometimes felt like a broken record with my patients, hearing similar concerns that I maybe got a little bit tired of addressing. And I think having a moment to reflect on any ways that that might impact my biases or come into the conversation that I'm having with the person in front of me is an important first step. First 5 minutes also talks about ways that we really need to first connect with our patients as people. And sometimes that small talk before the big talk can really help to improve that connection. It also reinforces the need to really make sure that we're setting strong agendas with our patients. I teach this to my medical students in their first few years when they're learning how to take their histories. That really is you're eliciting a patient's concerns, asking what else a couple of times, and then making sure that expectations for the amount of time you have together, things that I might have on my medical agenda that might be pressing or urgent, and then negotiating that agenda with the patient to make sure that we're really achieving our shared goals for that patient's health. And then when we apply these conversations for vaccine hesitancy, really making sure that we're starting with open-ended questions, that we're really exploring with the patient in a place of curiosity, what it is that might be driving some of their concerns or thoughts regarding vaccination. The first 5 minutes uses an acronym called PEARLS that looks at ways that we can address a patient's emotional responses. And when we think about this for vaccine hesitancy, doing things like making sure that patients' emotions are validated, that their responses and concerns, that we're reacting to those without judgment. Even sometimes just showing appreciation for their willingness to share their perspective, naming and validating some of the emotions that they might hear, might be expressing around vaccines, and looking for ways that we can in addressing that from an open-ended and really a non-judgmental fashion, be able to advance our conversation with the patients about some of their concerns. Really, finding that these can be emotionally fraught spaces. And as doctors, we sometimes want to just hide away from that emotion, just move right on past it, move into the science, move into the recommendations. But as any of us who practice in the ICU know, and when you're in emotionally fraught settings, um, really trying to bulldoze past that is not going to help advance your conversation and your relationships with your patients. And so taking those same kinds of skills that we use in those settings and really applying them here in vaccine conversations, which really can have some strong emotions or strong history from patients, allowing space for that, acknowledging it, naming it, and really validating how that patient is feeling. And so those are some of the ways that we can apply some of the first 5 minute techniques and core tenets to conversations around vaccine hesitancy. Dr. Maves, I wonder if you can share with me what strategies have you found most effective in building trust with patients who express vaccine hesitancy, particularly those who might have chronic pulmonary conditions?
I mean, it's a great question, right? And everyone's practice is going to be a little different. For me, one of the things that, there I think we all struggle with a bit is the challenge of combating misinformation. And really what that involves is creating an environment of trust where people feel comfortable discussing their fears and hesitations freely. And, obviously we live in an era where information on social media platforms spreads very rapidly and often more rapidly than the science. And one thing that I've found over time, because I think as we've discussed, this is often not a single visit challenge to overcome, but a thing we have to do over time as we establish relationships with patients is, first of all, obviously stating my recommendations to them clearly. And I tell folks that, hey, listen, I hear you. I hear where you're coming from. I understand. And tell them I am always going to give you the best advice that I have, right? And I emphasize to them that the advice that I give is also the advice that I follow myself. I have a picture of my phone of myself getting my COVID vaccine on the first day of its availability back in 2021, or actually 2020 in my case, and I suspect that's probably true for you as well. Um, but we're talking about, listen, I am walking the walk. The influenza vaccine, the COVID vaccine, the zoster vaccine that I'm recommending for you, I have gotten these myself, and this is my personal experience. And recognize that that may not necessarily set in initially, but then as we continue to work with patients, giving them a chance to hear them out, and then in the meantime, continuing to address their other concerns, right? Because people rarely come to you or to me solely for vaccine reasons, right? It's kind of a side thing that we're doing in the context of a broader um, clinical clinical evaluation. So making sure that as I am addressing the other things, I think people start to appreciate that, hey, there's some, to be a little jocular about it, there's some rando on Facebook who's posting all of this, all of these ideas about vaccines, who says I shouldn't get them. But on the other hand, Dr. Conroy or Dr. Maves, whom I am communicating with regularly, this person is listening to me. This person is answering my questions. And when I have a problem, this person is helping me out. Perhaps I should reconsider whom I trust. And that takes time, obviously, but I found that to be fairly effective um, as a way of addressing the misinformation. And that is by building a record of trust with folks that we care for. Accessibility barriers can become a bit of a challenge, and that lays somewhat outside of the realm of misinformation and trust. That just becomes a logistical problem. one of the difficulties we've had over the years is just the raw complexity of vaccine recommendations. And we're actually in a pretty good place right now from that standpoint, in that a lot of these vaccine recommendations have been simplified. A good example is pneumococcal vaccination for adults, where previously it was like for certain groups, we would give the polysaccharide vaccine. For other groups, starting like age 65, we would give the conjugate vaccine, and then we'd wait some period of time. Then we'd give the polysaccharide vaccine, and then maybe a booster at 5 years or maybe not. And now that's all pretty much gone. And for the majority of people, the answer is 20 or 21 valent conjugate vaccine, and that's it. Right. And those sorts of streamlining things, it's not directly an access thing, but now you've turned something that took 3 visits into a single visit. Another kind of interesting example, and I haven't seen a lot of press about this, but I actually find it very interesting, is that the nasal live attenuated influenza vaccine was recently approved by the FDA as an over-the-counter agent, which is to say someone can go to a pharmacy and just pick up an influenza vaccine and self-administer it. And I think those sorts of things to simplify access can potentially make a big difference. In other things, and you talked about this in far better detail than I can, but just the whole notion of empathetic listening, that, I think we've all been through the ringer in pulmonary and critical care medicine over the last several years. And it does, we are all human with human frailties and human peccadillos that make it hard for us on many occasions to really hear people out. And I think we do. It is a good opportunity for us to remind ourselves that it's not about me, it's not about you, it's about them. And taking the time to genuinely hear out patients' concerns, acknowledge their emotions, just like you've said, and let them know that even if they're not going to do what I want them to do on the first day, we'll come back to it. We'll come back to it. But I tell them, like, I am not the boss of you. And you and I have talked about this before, kind of informally, but I do wonder if we made a tactical error as a healthcare community in perhaps the more mandated aspects of COVID-19 vaccines. You talked about the cultural diversity, not just between racial and ethnic groups, but just between geographic groups across the country. I grew up in the Pacific Northwest, and people are usually kind of down for whatever in the greater Seattle area, right? And the same thing, I spent most of my career when I was in the military in Southern California, and culturally very similar there. Here in the South, things are a bit different. North Carolina is not San Diego. It is not Seattle. And I think that people often instinctively recoil or throw up walls when you are told you have to do a thing, right? And I certainly understand this. I understand this desire, and I wonder if we made a tactical error in pushing vaccine mandates instead of focusing more on persuasion, focusing more on relationships. I don't know. That'll be very difficult, I think, to prove in a level 1, high level grade evidence kind of manner. But, and for those of us who work in healthcare, by the way, there's a long-standing precedent for mandatory influenza vaccination. I think COVID vaccination falls very comfortably in the same framework. So for those of us on the job, I think vaccine mandates were appropriate and the right thing to do. But I do wonder more in the general population if we could have taken a different approach and maybe had a different outcome. That's just speculation.
Yeah, absolutely. And I think, to your points, as recommendations are simplifying, and as we're maybe in spaces outside of broad sweeping mandates, we might have the opportunity really to kind of readdress some of these things and take a little bit more of our time to focus on persuasion. And maybe persuasion isn't necessarily the right term. I might suggest thinking about aligning with our patients.
Yeah, that's a good word. I agree. That's a good one.
as we're sort of learning more on their hesitancies, giving the time and space to discuss that through open-ended questions, really taking it curiously with them, and as you described, sort of sharing your own experiences. That what you're recommending is nothing different than what you've done yourself and for your own family, and I've had similar experiences. I think I still can picture the faces of some of my most vaccine hesitant patients when I shared with them the story, that my young son, he's now 4, but at the time when he was about 1.5, I enrolled him in a trial for the emerging COVID vaccines, and he was in the youngest age group of those randomized controlled phase 3 trials. Which, as you noted, they were done quickly, but they were done with high quality, and we were randomized in a placebo to blinded fashion, and he got vaccinated. And when I shared with them the story of enrolling him in that trial, the reason why we did that, and really as an evidence of, the knowledge that I had on the safety of these vaccines, that I was willing to potentially in a randomized blinded trial have my son vaccinated for that, and ultimately he was vaccinated in the trial. But that was, I think, one of the more powerful ways that I could communicate to them just the way in which my knowledge of the safety of those vaccines and my recommendation for them really was founded in my strong knowledge and belief for that, and that I was doing the same thing for my family. And I think, as we get to know our patients over time and really build these relationships, another skill and something that I think for most physicians is easy to conceptualize using in these conversations is really the skill of motivational interviewing. And so, as a pulmonologist, we use this a lot for tobacco cessation conversations, but, really where we take a patient's goals, take a patient's concerns, take patient's self-stated, health interests, and then ask them sort of, what can you do to help reach that? What are barriers that you have to help reach that? And when we think about the benefits of vaccination, as you use motivational interviewing for a patient's disease state and think about, for me, what are your goals for your COPD? What are you hoping for? What are you most worried about? And then I can align my medical recommendations with those hopes and those worries to, for instance, stay out of the hospital from their COPD, to avoid exacerbations, and to optimize really sort of the stability of their respiratory care over a year. And vaccines are a really fantastic way to do that for several of our respiratory viruses. And really taking that patient's goals and through that motivational interviewing skill that we use in so many other settings, can be really easy to then align those recommendations and explore some of the vaccine hesitancy with the patient in a way that really directly correlates the reason why I'm recommending it to what it is that they want out of their medical care.
Yeah, no, that's fantastic. That's a great perspective to hear about the approaches that work well for you when addressing vaccine hesitancy with your patients. And again, your practices and mine are a little bit different, but I think that's actually really helpful for this discussion because obviously not, the diversity of our patients is in many ways reflected in the diversity of our own practices. For me, the place where it comes up most often is in people who are interested in kidney or heart transplantation. And the ethics and the math of those calculations are a little bit different. Heart transplantation is generally an acutely life-saving procedure. And I may need to tolerate a little more risk in a vaccine hesitant patient needing a heart transplant. Whereas with kidney transplantation, kidney transplants are in many ways a life-prolonging procedure. But with them, I also have a little more time. So I have more time to establish a relationship while they're on the wait list, while they're doing reasonably well, I hope, on dialysis, and can work with them to get them to a place that is acceptable to all of us, both from a risk standpoint, in anticipation of transplantation, and just then for their general health. I mean, these are folks with end-stage renal disease, and even if they were not being listed for transplantation, there's a bunch of stuff we got to do to help these folks out. And fortunately, we have a little more of a luxury of time there than we would in, again, say like a heart or a lung transplant candidate, for whom we're, the acuity and the urgency of that need may often be considerably greater. Oh gosh, what just a great conversation. Megan, I always learn so much when I talk to you. I'm humbled and grateful.
Yeah, thank you so much, Dr. Maves, for joining in today's discussion. And thanks to our audience for listening to Chest Pulse.